good afternoon, everyone. So we are pleased to welcome you to the first core knowledge hub meeting, which will focus on the HIV, viral hepatitis, and the STI testing and diagnostic landscape. This meeting will be recorded, and we will share the slides after the meeting. Please put yourself on mute if you can. And you can ask a question by clicking on the hand option. So what is CORE? You might all wonder what CORE is. So CORE is a European Commission co-funded project focusing on the community response to end inequality. The aim of the project is to scale up community-based testing, and it focuses on communities that are not yet adequately served by testing services. It focuses on people who use drugs, migrant communities, sex workers, transgender people, and and so on. So as you can see, the Knowledge Hub is a series of meetings, online meetings that are aimed at sharing best practices in community health services for communities most affected by HIV, TB, and viral hepatitis. And as you all know, we're just on the 2nd of May, and this May there will be the European Testing Week. If you haven't signed up yet to the testing week, you can do so by scanning the QR code that is here. So I will now introduce Viatcheslav Grankov from WHO Europe, who will provide an update on testing algorithm to modernize them. And then Cheryl Johnson from WHO headquarters in Geneva, who will update us on testing kits cost effectiveness. Over to you.
Thank you, Isabelle. Good afternoon, dear colleagues. I'm very happy to participate in this webinar. So I'm working in Copenhagen, WHO regional office for Europe, and it covers 53 countries, 53 member states. It's a vast region with very different situations regarding HIV, viral hepatitis, STI. So I will now share my screen. I will talk about updating and simplifying testing algorithm, and to talk about how to reach the first 95 and close the current gaps in HIV diagnosis. So a few words about context. So as you can see on the left part of the slide, we have a big problem with awareness of HIV status in WHO European region, especially in Eastern Europe and Central Asia. You can see that only a little bit above 60% of people living with HIV are actually aware of their status, positive status. Another problem that we have, it's on the left, also part of the slide. It's a direction that we have in WHO European region. So the estimated number of new HIV infection is increasing, while the detection new cases of HIV reported to WHO and ECDC are decreasing. So there is a growing gap actually in WHO European region. More people have become infected with HIV in the region that haven't been diagnosed. And another big problem, which is very crucial for our region, it's late diagnosis. And it remains like this for many, many years now without any substantial changes. More than 50% of new cases are diagnosed late. It means the CD4 level when diagnosed below 350. So, and if we look at the HIV cascade of care and compare like what happened in 5 years in Eastern Europe and Central Asia, we can see that substantial progress has been made in terms of putting people on treatment, achieving viral suppression, but not so much progress on the first 90 at that time, and now 95 was made, and still many people still do not know their HIV status. And this data is from ECDC monitoring implementation of Dublin Declaration. It was published this year, and you can see here 46 countries in Europe and Central Asia. Only 5 countries, according to this report, actually reached 95 target, and some of the countries are within 5% of target, but the majority of countries in WHO European region, including many countries from European Union, are still more than 5% away from their target. And the average number is 83% of estimated people living with HIV had been diagnosed. Also, regarding dynamics, countries of Eastern Europe and Central Asia have the fastest growing HIV epidemic in the world. We can see, while in the world, the trajectory is clearly with decreasing number of new HIV cases, but in Eastern Europe, Central Asia, it's increasing. And there is a substantial difference between East and West in WHO European region. You see on the right part of the slide that the number of new infections per 100,000 is actually 10 times higher in eastern part of the region. And 95% of all new cases are among key populations and their partners in Eastern Europe, Central Asia. And at the same time, men and key population are the most affected, and knowledge of HIV status in men in our region are much lower than among women. So what are the main reasons behind the remaining gaps in HIV case detection? Well, there are 3 main areas that we need to look. It's stigma and discrimination, obviously remaining, low access to services, lack of awareness and knowledge.
I'll be in the youth room, so yeah, Roshi. Sorry, I was half-assing our conversation.
Sorry, someone is unmute. Okay. So regarding stigma and discrimination, people do not feel ready or empowered enough and just afraid to get tested. They have a fear of confidentiality breach, or just it's because of unfriendly services. There could be insufficient funding, or just geographic availability problems, or inconvenience of services. And of course, lack of awareness and knowledge. Testing is for HIV and STIs, viral hepatitis, simply not perceived as a priority, or people are still not aware or do not understand their own risk of acquiring HIV ongoing or in the past. You know, we all been working for many years in HIV area, so we forget sometimes that people do not think about HIV and STIs and viral hepatitis the same way as we think, and so there are many problems. So regarding solutions, what can we do? Of course, normalizing HIV would be great, and changing societal attitudes, norms, and stereotypes. But unfortunately, it will take some time. So we can start doing it from healthcare settings, and it should be done everywhere. We should expand friendly, safe, and confidential services. Of course, we need to increase geographic availability, increase funding for testing, and decentralized testing services. And of course, we should work on demand generation, information campaign, including this announced European Testing Week is a great possibility to do this, wide use of digital solutions, sexuality education programs, and others. And all these issues are reflected in regional action plans for ending AIDS and epidemics of viral hepatitis and STIs in European region till 2030, where there is a additional priority, separate priority 1.5, ensure accessible, decentralized diagnostic and laboratory services. And we should always think about integrated testing for HIV, viral hepatitis and STI, because they have common modes of transmission, many populations affected by these diseases. And also its integrated services, testing services, allows synergies to be created in times of constrained resources. And we have in regional action plan these priority populations for HIV, viral hepatitis and STIs. And apart from key populations, we look here at pregnant and breastfeeding women, it's migrants affected by conflict and civil unrest, people with disabilities, and others. And for all key populations, in 2022 updated consolidated guidelines for key populations, for all 5 key populations, HIV testing, STI testing, hepatitis B and C testing, and screening, diagnosis, treatment, and prevention of HIV-associated tuberculosis are included in the recommended packages of services intervention. But in each context, we need to decide which testing approaches can be attractive and perceived as safe by potential clients, even in settings with current high level of HIV-related stigma and discrimination. WHO produced a number of recommendations, and both myself and my colleague from our headquarters, Cheryl, later will be talking about it. And so first, it's about adapting national HIV testing strategies. So recently we moved from having the notion of confirmatory test to new, it's confirmation of HIV infection by combination of 3 reactive test results. So it's not an individual confirmatory test that gives an HIV diagnosis, but it's a combination of 3 reactive tests. I will not go into details. It's usually we give more details for lab specialists working in health facilities, but it's very important to ensure quality of the tests used, and the sensitivity recommended by WHO should be 99% or higher, and specificity should be 98% or higher. And ideally, the test should be WHO pre-qualified of guaranteed quality. But of course, European Union has their own very strong regulatory mechanism to ensure that the tests are used of high quality. And now I will talk a little bit about moving away from Western blot. So Western blot, it's a type of test that is still widely used around the world, and including in European Union countries. This on this slide, it's results of the meta-analysis that compared testing algorithm with Western blot and without Western blot. And so what was interesting about these results, that sensitivity and specificity of this testing algorithm were comparable. So they were not distinguishing, but there was high rate of indeterminate results with algorithm containing Western blot. So you can see that in comparator, so testing algorithm with Western blot, there were 81 indeterminate diagnosis, indeterminate result compared to 0 in testing algorithm without Western blot. And in 46%, they were from specimens that were positive, and 54% were from specimens that were negative. And in both cases, we, have problems, because if they were positive, so we delay linkage to care, we delay linkage to treatment. But if they were negative and but were indeterminate to Western blot, it means that we had a period of worrying for the person, because people do not know what are their results, whether they are positive or negative, and it's a lot of anxiety and problems with that. So apart from higher frequency of indeterminate result, Western blot has lower sensitivity in the early stages of infection. It's longer testing procedure than for rapid diagnosis test or just ELISA test, more time consuming, and there is of course need for specially trained staff. Usually cost per test is higher for Western blot than rapid diagnostic test and ELISA, and higher loss to follow-up and lower linkage to care with Western blot algorithm, because people need to wait for their results. And on the right part of the slide, it's estimated mean window period, so time from HIV infection to immunological reactivities in days. And you can see that, for example, if you use fourth generation tests for screening, they can be reactive quite early after the infection. And what you can get, that person is after tested with fourth generation tests, then goes into Western blot in majority countries, and it leads to undeterminate results, or which requires these people to come again in a few weeks' time to retest and to confirm the diagnosis. But we cannot just take any tests, any combination of tests, because it can give create some problems. And for example, if there is a cross-reactivity between tests, so if the first test is, for example, false positive, then the next test can be also false positive. And that's why WHO recommends to perform verification studies, in order to identify the combination of tests with minimum possible common cross-reactivity. And we support currently several studies, verification studies in Kazakhstan, Georgia, Armenia completed, and now there will be a pilot. Ukraine completed this kind of studies, and we recommend other countries to follow these procedures. Also, WHO recommends late providers testing and rapid diagnostic tests, because it leads to better uptake, and it's usually preferred by clients. In all studies, individuals preferred rapid diagnostic tests over lab-based methods. It's lower cost and portability, and it still gives accurate diagnosis equivalent to laboratory method, and same day to start treatment. And using rapid diagnostic tests, the diagnosis can be confirmed within 1 day. And WHO currently recommends that treatment should be prescribed on the day of confirmation of diagnosis, and no later than 7 days from the confirmation diagnosis if additional examinations are necessary. HIV self-testing, I won't stop here because Cheryl will be covering this. Also, we should not forget about so-called social network-based approaches that are recommended. It's a process when individuals, including those with newly diagnosed HIV infection, or at ongoing risk of HIV, for example, key populations, are encouraged to offer HIV testing to social, sexual contacts in their network, and maybe at risk of HIV. And in our countries, in some countries of our region, it proved to be very effective, very effective.
Slava?
Yes?
Just you have 3 minutes
Yes.
left.
Okay, thank
Sorry
you.
for interrupting.
Virtual interventions are very important, and we should work with health professionals and educate them about indicator condition testing. So unfortunately, many studies in our region show that in many cases, when the people were diagnosed late, actually they had many missed opportunities. So they visited health facilities and they were either not tested or not offered testing. And it's in Spain, in the UK, in Estonia, the same problems about missed opportunities for HIV testing. People, as a result, are diagnosed quite late. And we should not forget about general population, not only key populations. We can see that late diagnoses are especially prevalent among heterosexual men and heterosexual women who do not consider themselves at risk and as a result are not tested. And the health provider usually do not consider them at risk. And we have great examples, for example, involving primary healthcare in HIV testing in Wales, and it gives very good results and uptake. And we should use testing as a gateway to prevention and treatment, because if person is tested HIV negative, then we should link this person with prevention services, including PrEP if needed. It's my final slide. So we need to decentralize, simplify HIV testing approaches, and expand peer-led partner contact tracing, reduce delays in diagnosis confirmation, so using more rapid diagnostic tests, point-of-care tests, discontinuation of Western blot, and linkage to care, self-testing, self-sampling, expand indicator testing for HIV, and ensure accuracy test results. And we shouldn't be afraid to switch from instrumental laboratory-based testing to a system using rapid diagnostic tests. You know, many years ago, in order to call someone, you needed to have a team of telephonists who would communicate you with the person manually. Then we got a new technology, and now we can call each other without any additional barriers. So we should not be afraid of progress, and it cannot be stopped. And we encourage you to support these recommendations. I'm very grateful to my colleagues from headquarters, Cheryl, Celine, and Anita, for their support in our region, WHO European region, in updating of our testing algorithm. Thank you for your attention.
Thank you very much, Slava. We will take the questions and debate at the end after Cheryl's presentation, but if there is an immediate question for clarification, please raise your hand. Otherwise, we'll take the Q&A afterwards. No? So Cheryl, please go ahead.
Hello, everybody. Thank you so much. An excellent presentation from Slava. I'm just going to go ahead and dive in, but just to contextualize, I'm talking a little bit more about HIV, hepatitis, and STIs in this presentation. So just as background, I think for WHO, we do have the global health sector strategy of, why are we talking about testing across all three kind of disease areas? If we really want to make progress, we recognize that we're going to need access to affordable, accurate diagnosis and diagnostic tests that are cutting across HIV, hepatitis, and STIs. And this is really highlighted in the strategy. Now, Slava's gone over some of the gaps specifically around HIV testing in Europe, but I want to point out also the gaps on hepatitis, that to say right now, in terms of, people with hepatitis C who are aware of their infections, only 29%. Likewise for hepatitis B, it's only just a little bit below 16%. So we have much lower testing coverage. And we know in the region for Europe, there's actually very little testing and self-testing available, which is kind of a gap as well when we think about the strategies that we can use to accelerate testing, treatment, and care. And for STIs, it's just to highlight that we have seen these trends of increased cases. This is something that was highlighted in the recent ECDC report, which really highlighted that testing, treatment, and prevention, they lie at the heart of the long-term strategy. And so we do need to be doing more when it comes to STI testing as well in Europe. So all the guidance across the 3 areas is covered in these different documents. I'm very happy to provide those if anyone's looking for a specific document. And just to note that the 2024 HIV and STI guidance is forthcoming. So those should be published later this year, but all the recommendations for HIV and syphilis have been posted online. So also happy to share those if that's helpful to contextualize anything we share in this presentation. But across the 3 areas, I think it's just important when we think about applying these guidelines and what the best testing is, we really use this DSD framework. We think about how we're mobilizing the right people, how we're testing, delivering those services, and then also supporting the linkage to prevention and to treatment. And I think this is a helpful framework to think through how we start to select which technologies or which actual tests for what we want to achieve in our programs. And really, we kind of break things down into the 3 testing areas across HIV, STI, and hepatitis. And we've got more case finding focused testing that's going to be very targeted. And we're going to pick some tests that are all about getting testing to people who are probably at the highest risk. We're doing some really targeted outreach. And then there's going to be some prevention focused testing where we might be taking advantage of a routine visit. Something where we want testing in a place where it's serving a big population need, so we can get really high coverage really fast. So that could also drive, which tests we pick based on what we want to achieve. And some of the other factors that come into selecting which technology we might want to use also comes down to who's doing the testing. So it could be, do I have lay providers? Do I have lower cost cadres that can do implementation of testing? Thinking through all those levels of exactly, what's the simplest, most affordable way to deliver testing based on the entry point that I'm really considering. And right now, in terms of the tiers, this is just the pyramid of when we kind of think about how testing might be separated out. Some of the higher level technologies, they're going to be really limited to the district, provincial, or regional, or national level. And when it comes down to primary care and community outreach, we're really talking about a lot of self-tests, testing at the point of care, and your simple rapid tests, because that's, especially for HIV, that's 95% plus of where all the tests are really being done, because that's where the populations need to be reached. And increasingly, I think we're seeing this for STI and viral hepatitis, especially as new options are becoming available. So just to orient the group on self-testing, it is a really critical part of self-care. And when we think about kind of expanding UHC, it's kind of a cornerstone when we think about how are we going to actually get the coverage we need to achieve elimination and epidemic control type targets. And ultimately, the justification around self-testing is it's supposed to achieve some direct impacts, both on, it can enable more sharing of knowledge of status. It can help link to prevention, link or relink to treatment. But really, this being triaged out of the health system is a new value opportunity where we might have people who, we've been using a lot of financial resources at the health facility to provide testing. But maybe if we introduce self-testing, we can reduce facility visits, save health worker time, think about additional options. And then there's also these additional benefits that are also worth thinking about, where there may be some kind of reducing the client opportunity cost or having other social benefits when it comes to introducing these approaches. So when we think about the different IVDs for testing across kind of different platforms and technologies, it really is 4 main categories. So we think about rapid tests, we think about self-tests, kind of the simple assays and immunoassays, and then our NAT technologies. And so this is something where I've kind of broken it down about there's different places where the testing can take place, but there's going to be different considerations around whether a certain technology might be suitable based on what you want to achieve and what the actual implementation looks like. So even if you're saying you want the most accurate test and you're thinking about NAT, if you don't have kind of the ability to store kind of the materials to provide the staff with the sufficient skill level, have the equipment and kind of consumables required, as well as the quality control for that, it might not be the best fit. And so what we often see, actually, especially with the outreach and a lot of the scale-up programming, is we're focusing largely on the most programs selecting things like rapid tests and self-tests, which is where I'm going to focus around on the cost effectiveness. That's not to say EIAs and NAT don't have a role. They absolutely have a role. But when we think about where we need to go to fill in gaps and increase access, rapid tests and self-tests are really the most suitable for that decentralization model and to really scale up where we're seeing testing coverage, for instance, in hepatitis of 16%, 29%. Those types of numbers are so insufficient that we really need to be thinking about expanding the types of technologies we're offering routinely. So in terms of the rapid tests that are available in the pipeline, I've just summarized a little bit of what's in the PQ list, and there's a link at the bottom of this slide as well if you want to go through, and you can pull each public report. But we have an array of offerings of around 15 different HIV rapid tests, with 1 under assessment currently and 3 under assessment for self-testing at PQ. We also have multiplex products like the HIV syphilis rapid tests, as well as 2 other single syphilis rapid tests that are available for procurement. We have 1 hepatitis B rapid test and 5 HCV rapid tests, as well as 3 additional HCV rapid tests under assessment. And then in terms of STI diagnostics, PQ is actually starting to broaden their scope, and we'll be including STI diagnostics in 2025. And so there's also some exciting opportunities of what might come in with that, that will have new lateral flow, kind of some of the antigen assays. There's a recent publication just in February this year highlighting some of the options that might start to exist there to help scale up STI testing. And we know that there's several other multiplex rapid tests in the works. So there's 1 panel that's currently under assessment for HIV, hepatitis B, and syphilis. And then we also know of some interesting STI multiplex with chlamydia, gonorrhea, and trichomonas all on 1 test. So lots of things happening in terms of the offerings that could be available and could be important to think about. So now let's dig into the cost effectiveness. So as Slava has already outlined in the testing guidelines, there's a lot of reasons why we might want to choose different testing approaches, but let's break it down into what we know about the economic side and the value add. So first and foremost, when we've looked at implementation of that community outreach, those network testing approaches, they have been shown to be cost effective when highly targeted, particularly among key populations and groups with higher risk. And so it's really about getting, I think, the right targeting for these strategies. And one critical way to implement those approaches is the use of lay providers. And lay providers are so essential, I think, to the service delivery models that we do and what we think about. Sometimes they're not as well supported as they need to be in order to achieve scale. And I think when we talk about lay providers, this general assumption that there's probably some savings or some financial benefits of thinking about lay providers. But there was 1 randomized control trial that pulls this out really well, which showed, that when we really compared the cost effectiveness and the value add of lay providers versus health workers, in addition to lay providers having greater uptake of testing when compared to health workers, we also see that it's a more cost-effective option when we implement with lay providers than just health workers alone. And likewise, when we think about the shift away from the Western blot, we know from the systematic review that Slava already mentioned that there's definitely cost implications and benefits of shifting to a simpler testing algorithm and strategy. But we also have seen directly from countries, those that have shifted away saw, not this kind of major reduction in the turnaround time. And they also saw that they were able to recoup savings quite substantially, even just in the matter of a few weeks of implementation. Now, one thing that I think is really important to think about, particularly for Europe, and is very much in the spirit of the European Testing Week and all the work that everyone is doing to bring testing services together, is about integration. There was a systematic review that really pulled this out, and it looked at kind of HIV, hepatitis B, and C testing. And one of the key conclusions was not only was it effective in increasing case identification overall, but by integrating or offering kind of a triple test type of approach, we could have identified so many more cases. So for every individual diagnosed with HIV, another 5 would be diagnosed with hepatitis B and 3 with HCV. So I think that not only are we seeing the benefits, the findings from the review pulled out the costs, that if we had tested for these viruses separately, we're talking close to $3. And that's marginally less expensive. That's, you know, pretty good value for money versus just spending money on, say, a single HIV test, which may be the case in several countries. So I think that this is a great opportunity to kind of think about clearly integration for kind of HIV and hepatitis has a strong kind of economic case here, and it could be a really good option to think about. Now, I think we're very fortunate in HIV and syphilis to actually have multiplex products. And having a multiplex product can be really helpful in terms of kind of scaling up that integrated model. And so here we've got 3 pre-qualified HIV syphilis dual tests. Now we've seen uptake of these tests globally, and I think we're seeing a lot of use, particularly in relation to increased syphilis rates globally. Think how we can scale up and really address things like congenital syphilis, which really shouldn't be happening in 2024. So when we think about that, we know uptake in Europe is low, but the cost effectiveness in the value add case is really strong and one worth thinking about, especially in antenatal or in key populations where we're seeing increased syphilis rates and we might not have the coverage and all the testing sites where we really need to have it. So just to highlight from some of the literature and some work actually that informed the guidelines, in antenatal, we see the use of the dual test, even in Ukraine, which was part of the WHO guideline process and analysis, that they've had significant cost effectiveness, including the dual test as well as with a retest in the 3rd trimester. And this was the case in all the settings included in the guidelines process, which had varying ranges of HIV and syphilis prevalence. And then we also have an example coming from Vietnam where we found, you know, kind of those key population-driven epidemics, which would be very similar to a lot of what's happening in Europe, that the kind of annual testing with a dual test or even biannual testing would be cost-effective and much cheaper than having just the single HIV and syphilis rapid tests used. And so these similar strategies, kind of thinking about what we just saw with hepatitis, we can kind of draw on a similar explanation here that integration using these multiplex tools could be really effective in increasing testing coverage, not just for HIV, but for syphilis, which could be really important to achieving our kind of regional and individual goals. Now, in terms of self-testing, I think there's a lot of literature out there. Multiple studies have shown self-testing across HIV, hepatitis C, and syphilis can be cost-effective. So across low and middle income countries, a recent systematic review did report there's a wide variation, and some of that has to do with the way in which self-testing is implemented, making sure it's targeted appropriately, and there's a lot of variability in how it's used. And right now, I think most of the uses of self-testing have focused on treatment, but I'll share shortly about actually what's happening within PrEP and PEP delivery, which could also be a really interesting option. But in general, the cost per person tested and diagnosed are usually within range of cost of effectiveness. And we also see that there may be some implications, though, for the delivery models to think about the linkage, some of the post-test support to make sure that whatever is being selected is going to really ultimately have the greatest impact. But that does have cost implications. Now, I will say that from the review and the evidence available, it's pretty compelling that it is cost effective, but there is a lot of variation to think about adapting self-testing for different settings that needs to be considered. There is a recent study just from February in 2024 in the US that said even where self-tests were highly expensive, which may be very similar to Europe, it was actually a kind of less kind of a cost-effective option, even if it was a more expensive test and its ability to really reach certain groups, it still was beneficial. And so I know really to make self-testing work, we need to adapt models for Europe, and there may be some efforts needed to really support policy change and better financing models for self-testing. Now for hepatitis C, we have kind of from the literature seen that it can increase costs, and that's particularly driven by the scale up of the hepatitis programming, where you're going to kind of diagnose and cure more people, which is what you ultimately want to do. So really to achieve cost effectiveness with the hepatitis C self-test, it's best used when you can focus on the highest burden or highest prevalence populations. And then with HIV syphilis self-testing, this is a new recommendation out of WHO just from announced last year. And we only have one study that's really looked at cost effectiveness, and that's coming out of men who have sex with men in China. But what we saw is a substantial reduction when we looked at the standard of care versus the self-testing option. The cost per person tested was about $27 for syphilis self-testing, which was HIV and syphilis together. And that is compared to the standard cost of testing, which was around $66. So quite a bit of savings there when they introduced self-testing. So as I noted, cost drivers are going to be contextual, and there may be additional opportunities for savings when we think about how can we use virtual interventions, artificial intelligence. Some of the secondary distribution models are also really kind of savings in the sense that you can kind of distribute self-tests through networks without having to have as much facility contact, which could be really kind of beneficial. Different schemes around coordinated procurement or reimbursement through insurance schemes, also very helpful. But ultimately, it's important that we think about self-tests that we're using kind of the quality products, but also really advocating for affordable products. Now, as I kind of alluded to, there's emerging evidence now, and we do recommend the use of self-testing within PrEP delivery at WHO now. And this can be for PrEP initiation, reinitiation, or continuation. And we're starting to see that actually self-testing could really be beneficial to the PrEP program in its ability to simplify delivery, reduce time needed by health workers, really reduce the opportunity costs from the clients who they won't have to travel to the clinic or they don't have to come in as often. And this is increasing cost effectiveness of PrEP, getting more people access. And it also gives us more diversity of models we can offer. So things like teleprep or online or app-based support tools. We can do a lot more with a self-testing based kind of PrEP model. And we've got recent modeling coming out that showed even in really high burden settings where we might be concerned about more transmission, we're not seeing that to be an issue. The costs would be similar if we use standard testing. The value add to the patients and the clients is much better. And there's a very low risk of drug resistance that we've observed. So I think this is something that's a really interesting proposition for self-testing in Europe, is to think about PrEP and PEP implementation, because we want to scale up PrEP, but we're really limited by the existing testing infrastructure. And maybe this is a great opportunity to really expand things further. We do have a number of pre-qualified HIV self-tests. The prices through the Global Fund are very competitive. They range around 95 cents now to $3.10. The private sector availability in Europe is pretty strong, but we know that the costs are high in this region. And then in terms of hepatitis and syphilis, we don't have pre-qualified products yet, but there are several in the pipeline worth noting. And just to say, you might be thinking, oh, well, it's just never going to happen that we're going to have affordable self-tests in Europe. But I did want to just say, I've been working on self-testing for a really long time. And when we first, really started to see a lot of things happening in the US, the price points were around $40 to $50. And in the low and middle income market, it was around $4 to $5. And through, I think, a lot of engagement with policymakers, different strategic leaders, we've been able to really make movement in high and low and middle income countries around pricing. So I would say don't give up hope. And I think that there's a great opportunity to think about how can we use these lessons to really support access to self-testing in Europe. And this is just giving you that timeline that, from the time that self-testing was really first discussed at the really beginning of the HIV response, we've come a long way, and self-testing is really becoming quite the standard of care for a lot of disease areas. So I think it's an important one to plan on and think about building capacity on in Europe more broadly, not just focused on HIV, but really thinking how do we support self-care and self-testing systems in the region. So just a few things to kind of close with. When it comes to our kind of testing approaches and service delivery, it's important we really are focused on testing services that are going to achieve that great impact, that are supporting increased access and equity. Like, it doesn't matter if the tests are super sensitive and no one gets them. I think that that's a really important guiding principle, that we're using quality assured tests. We're trying to make sure we're getting the right products to the right people, but contextualizing this within a public health approach. Integration, I think, is such an important cost effectiveness and high impact model to highlight. There's so many opportunities now through service delivery as well as through multiplex technologies. And we could be doing so much more with this and really not just having an impact on one disease, but multiple diseases at the same time. But we really need to invest in the systems to prepare for those products, those that are available, but also those that are coming. And then we have to advocate for investment in strategic testing approaches. So we need community services. They need funding for the long term. Outreach, especially testing with lay providers and rapid tests, is really worth it. It is such a critical investment, and it's needed particularly for key populations. Self-testing is a really big gap for Europe, and it's something I think we need to think about broader support to policy changes and ways to finance across disease areas to really enable that. And PEP and PrEP delivery could be a strategic opportunity for Europe to think about, where to start or how to really make the case to policymakers. So just to say, if there's any questions around HIV testing in general or testing services, my email is available. We've got some different resources that will be shared, and all those are hyperlinks that you can click on. And I just want to thank all my colleagues at WHO, Slava, and the whole team in the HIV, hepatitis, and STI program for their support. And back to you and the core team. And thanks again for the opportunity to share in this webinar.
Thank you very much, Cheryl. This is very appreciated because many of the people on this call are service providers. So to have that information is important. We have about 10 minutes for question and answers. Please raise your hand if you have one. I see Marco, you have your hand up. Please go ahead.
Hi, everyone. Marco from Italy. I have a question. Some pharma companies that sell dual prevention dual HIV and syphilis test don't provide Windows period in the instruction document. So how can we offer a good testing service if you don't know exactly the test Windows period?
Slava, would you like to answer this one?
I'm not sure why they do not provide, because usually instructions give this information about this window period for example, and it depends obviously of the test, because of the generation of the test. It can be third generation usually, it can be fourth generation tests, and so the window period should be included in the information about the test. I'm not sure, maybe Cheryl can give more precise information because probably she's aware about this process of
I mean, my first question would be, is this a quality assured test? I think if they're not giving you the window period information, it might be raising a red flag in my mind that I'm not sure if this is a regulated product. So that it may be, and there might just be like a missing piece of information. But I think what I can say is we've got the 3 pre-qualified dual test options, and I'll put the link in the chat if you want to take a look, and then let Slava and I know if it's a specific product. I can always look it up and get more information on a specific product.
Thank you. Johan and then Luis.
Hello, everyone. Thank you, Slava. Thank you, Cheryl, for your presentation. I have 2 questions. One is how WHO plans to promote this recommendation toward the national governments. And the second, it's relate artificial intelligence and machine learning. And if you can have with us an overview of planning to use the intelligence, artificial and the learning machine in the testing process, and how can we use this technology? Thank you.
Thank you. I can start about what we are doing in order to promote WHO recommendations. So of course, we are sharing them with the same kind of seminars, webinars with national partners, regional communities, regional technical partners. At the same time, we are trying to convene some different meetings And last year in Sevilla, we organized a WHO guidelines dissemination meeting where we invited HIV program managers and community representatives to Sevilla in order to discuss and introduce the latest updated guidelines. And in countries where we have country offices, it's not all the countries, obviously, and we have dedicated staff who are working on specific areas on communicable diseases. We are working more closely with partners and updating national guidelines. Another mandate that WHO has, it's so-called WHO HIV program reviews, comprehensive HIV program reviews. So each year we are going to several countries. Last year, for example, in our region, we visited 5 countries and we assessed for the implementation of WHO guidelines. And at the end of the review, we provide them with the report with concrete recommendations, on each step and each area. For example, on HIV testing, what to do, what we recommend to change, etc. But of course, for this, we need a request from national government to perform this HIV program review. And the most important part, it's actually networks and networks of specialists, network of communities, network of civil society organizations. And that's why we are trying to be involved in these networks and meetings. And because, in many countries, it's exactly communities and civil society organizations that push for a change much more effectively than, this international bureaucratic organizations in our good or bad terms. So and this meeting, and we are very grateful to Co-Initiative for organizing this mission. It's one of the actual examples how we can promote WHO recommendations in implementation. Thank you. But regarding the second question about AI, probably Cheryl can.
Yeah, no, a really great question on AI. So I think I've included the guidelines that were just released in January, and I'd really encourage folks to take a look at the chapter on diagnostics, because I think there's a lot of really good information about the kind of the models that are used. We are working, I think, internally. We have a diagnostic course at WHO across different disease areas about the use of AI. So broader than this talk today, but would be more than happy to share back with the core members things about AI. One exciting, I think, use of AI that we're really starting to see in Australia and in parts of the US, even with some of the monkeypox outbreaks, have been using AI for some of the skin diseases and thinking about how you can use AI to really do diagnosis when you don't have traditional testing available. So I think that there's a lot happening right now, but we will be working on some guidance and some work within PQ about approving different AI tools for diagnosis. So things coming, but take a look at the current chapter as well.
Thank you very much. We have 5 minutes, a few minutes left. I don't know if you are able to stay a couple of minutes. Okay. Thank you. Luis, go ahead.
Okay. Thank you. Nice to see you again, Cheryl and Slava, and thank you for the presentations. I have, I think, 4 questions. First of all, is there a recommendation, a document from WHO that recommends the inclusion of community workers or lay workers in testing? Because I'm working with 5 African countries, and Cape Verde is the only one where it's not allowed it. And they say, the authorities, that the document from WHO would be helpful to change the regulation. So it's more to give the link. The second question regards to pre-qualified testings for viral hepatitis. Our experience is that there are very few pre-qualified testing for viral hepatitis, and that in the private market, they are very, very expensive in Africa. And as Global Fund doesn't finance the tests for viral hepatitis, it's very difficult to scale up tests for HCV and HPV in African countries. So if anything moves, let us know, because we think it would be important. Pre-qualification became more of a barrier than an opportunity in some cases. And we have plenty of tests that are validated in the European Union, at EMA, etc., that are not pre-qualified because the producers don't have interest in pre-qualification. This is the third question: is there anything moving on the core antigen test for HCV? Because we have a big difficulty both here in Portugal, but also in the Lusophone countries, to make the confirmation with the very expensive and not point of care CFA testing. And many of us think that the core antigen that was already discovered could be at least partially a solution, but we don't see it available. And I think that's all.
Well, maybe I can just come in really quick and just say, for lay provider testing, we full stop recommend it. There's lots of different guidance out there, but I've just shared you the one that I think could be simple because it's a policy brief, 2 pages. So please let us know if you need anything else on lay providers, but full stop support. In terms of the kind of products, we absolutely, PQ should not be a barrier, or unnecessary barrier, because we don't want bad products getting in, because they really undermine, why spend all this money to do testing if the testing isn't going to be useful? I think that that's an important thing. There are options, so ERPD, the procurement list from Global Fund. There's other products that can be procured for sure, so I would use those opportunities. And then there's even the essential diagnostics list, so we're always taking submissions. And I would actually point out, and I'll share in the chat, we've just launched an EDL call for hepatitis D virus tests. So that could be another thing just to think about, and I'll put the link in for the call for submissions. That, we have different levers we can pull at WHO. It's not all PQ. It's a really important part of the kind of quality assured diagnostic space, but it shouldn't be the limiting factor. Utilize all the different channels you can. And I think we're here to help navigate those. If you have questions about, can I procure from Global Fund, from their list? Do I have to wait for PQ, or where are we at in that process? Or even if it's something around the EDL itself and trying to utilize that and what's listed and the different submissions that are coming in that way as well. Then in terms of core antigen, tough question. So I think what I would say is probably I can follow up. Find, I know, was doing a lot of work on the core antigen hepatitis C product. Probably to get the best information to you, I need to go back to them to see where they are, because to my knowledge, they were working on it and then it kind of stopped moving forward. So I don't think it's moving at this point, but I will follow up and certainly get back to this group.
Yes, I send you an email, so you can also reply, so you have my email.
Perfect.
Thank you.
Thank you. Is there any last question? Because we have to go soon, and I would just like to make an announcement before we leave.
If I may say, because I was reading the discussion in the chat, it was a lot of talking about normalization of HIV. I mean, we should understand what it meant by the concept of normalizing HIV. Because we still, unfortunately, live in the world where the majority of people, communities, and even healthcare providers, they still live with this concept of HIV of 1980s or 1990s, with its fatal disease, with the plague of 20th century, etc. And while we can clearly see that HIV now is more or less chronic condition that can be effectively managed, and people living with HIV can have a normal life, happy life, with pretty much the same life expectancy, but it's not become, you know, normal attitude in our societies. And that's why normalization of HIV, it's a concept about changing it, because this exceptionalism of HIV creates and fuels stigma, discrimination, and we still have 16 member states in WHO European region that have disease-specific HIV criminal laws in their criminal codex. So it's, of course, we want to normalize in terms of, you know, making it as any other chronic condition, and it will help, of course, to decrease the levels of stigma and discrimination. And there was a question about specifically LGBT and gay men, I believe, testing about recommended services. Of course, it depends on the context. I wouldn't say anything new to you, but there are different low thresholds, for example, online mediated services, like, for example, in the Netherlands, you know, this test lab, very effective work when people are not afraid of, to approach these services online, and it creates greater possibilities if there is a stigma and discrimination in countries. Of course, self-testing would be very great opportunities for gay men or MSM in general. And we know the practice of checkpoints, which is widely present in WHO European region. So many possibilities, but I wouldn't say anything like new exists that would help you a lot. Yeah. In each context, it can be different modalities. Thank you.
Sorry. Thank you very much for both of your presentation and the questions. We have to wrap up this call, unfortunately, but it's to be followed up. Thank you. We will distribute the slide from Cheryl and slide, because there were a lot of details into it, so you can have a look at your pace. We would like to announce the next Knowledge Hub webinar on the 19th of June, which will look at gender transformative services. And we will have 3 speakers. We'll have Aura Roy from Medicineres in Spain, Amanita Calderon Cifuentes from Transgender Europe, and Cristina Pires from Cosmic Care in Spain. So stay put. And as we mentioned, the Knowledge Hub is a series of meetings. So over the course of the year, you'll have new opportunities to learn from each other. Thank you very much. And we'll send, please reply to the evaluation that you will get, because it helps us improve the meetings. Thank you very much. Bye.